Welcome, everybody. My name is Laura Hanisch, and I work on the patient information team at NCCN. And I have a few slides to cover before the presentations get started. So what is NCCN? NCCN stands for the National Comprehensive Cancer Network. NCCN is a not-for-profit alliance of 31 leading cancer centers across the United States devoted to patient care, research, and education. NCCN Foundation is a nonprofit organization that raises funds for NCCN patient resources. So one of the patient resources is the NCCN guidelines for patients. They are based on the NCCN clinical practice guidelines used by healthcare providers worldwide. They explain options for cancer care and are written for patients and their caregivers, family, and friends. You can view and download free copies of the guidelines for patients from the NCCN website. You can also purchase a nice high-quality copy from Amazon. The Know What Your Doctors Know webinars complement the NCCN guidelines for patients. They cover a series of topics discussed by expert presenters, and at the end of the webinar, there is the Q&A section. So now I'm very pleased to introduce today's presenters. The first presenter is Dr. Ganti. He is a professor of internal medicine at the Fred and Pamela Buffett Cancer Center. He's also the chair of the NCCN panel on small cell lung cancer. Following Dr. Ganti, we will hear from Wendy Iverson. She's an oncology case management nurse at Fred and Pamela Buffett Cancer Center. Following Wendy, we will hear from Charles Florsheim. He's a patient advocate, survivor of multiple cancers, and a retired attorney. So at this point, I will turn it over to Dr. Ganti.
Good afternoon, everyone, and welcome to today's presentation. Thank you, Laura, for arranging this and allowing us to speak on this important topic. I will be speaking about small cell lung cancer, its staging of a small cell lung cancer, the basic treatment options, and following that, I will talk about clinical trials and some of the newer research that is ongoing in this particular area. So as a background, small cell lung cancer is a neuroendocrine cancer. It is classified in the group family of cancers that belong to this particular classification. It makes up about 15% of all lung cancers. This incidence has been decreasing over the last 15 to 20 years. Back in the late 1990s, that number was about 25%, but because of the change in smoking habits of the US population, more recent estimates suggest that small cell lung cancer makes up about 15% of all lung cancer. The male to female ratio currently is 1:1, and while the incidence of small cell lung cancer is decreasing overall, it seems to be increasing proportionately in women. What do I mean by that? Back in 1973, women made up of 28% of all patients with small cell lung cancer. 30 years later, in about 2002, that number went up to 50%. Small cell lung cancer is the fifth leading cause of cancer deaths in the United States if you looked at small cell separately from non-small cell lung cancer. And there are about 34,000 new cases every year of this particular disease. It is seen exclusively in smokers, but a common theme in medicine is never say never. And along those lines, we know that about 3% of women with small cell lung cancer have never smoked. Whereas in men, never smokers, small cell lung cancer has not been reported at all. The interesting thing about small cell lung cancer is it is very responsive to chemotherapy and radiation initially, but it almost always relapses. And that is why the 5-year survival is so bad, as you see in this slide. If you looked at all patients, only about 3 to 8% of patients will live 5 years after their diagnosis. And if you look at early stage lung cancer or limited stage small cell lung cancer, About 10 to 15% of those patients are alive 5 years after their diagnosis. This is what the pathologist sees when we take a biopsy and they look at it under the microscope. The top two stains are called H and E, hematoxylin and eosin, and that stains the cytoplasm. The pink you see is the cytoplasm and the dark blue you see is the nucleus. Normally, you would expect this to be half and half. The cell is made up of cytoplasm and then there's a small nucleus in the middle of it. But if you look at this blue, it seems to take up the entire cell and you hardly see any pink in it. That is pretty classic for small cell lung cancer. And once the pathologist sees that, then he starts wondering about small cell lung cancer. And then they recommend additional stains. And the classic additional stains that we typically do for any neuroendocrine tumor are two stains. One is chromogranin and the other one synaptophysin. And as you can see in these orange dots here, the orange means that this particular specimen is staining positive for chromogranin, whereas here it stains for synaptophysin. And when you have these two positive stains combined with a specimen that looks like this, the diagnosis of small cell lung cancer is made. Once we have a patient who has a cancer, the next step is to try and identify where all the cancer has spread. Is it localized to the lungs? Has it spread to the other parts of the body? And that is what we call the staging process or the staging workup. For small cell lung cancer, typically I tend to get a CT scan of the chest, abdomen, and pelvis, and a brain MRI. Occasionally, I tend to get a PET scan to rule out distant spread, especially if the CT scan of the chest, abdomen, and pelvis does not show me any obvious evidence of spread. If, on the other hand, I see that the liver is involved based on the CT scan, a PET scan is not necessarily going to tell me anything more, and I try to avoid that in those specific circumstances. Once I've obtained these staging studies, the next step is to stage the patient. And we have two methods of staging small cell lung cancer. One is the TNM staging, which is similar to what is used for most other cancers. And the second staging system for small cell lung cancer is the VA staging system, developed by the VA lung cancer study group back in the 70s. And it is more practical as it allows for making treatment decisions easier. Now, when we look at the TNM staging, T stands for the tumor size, N stands for lymph node involvement, and M stands for metastatic disease. So if you have a small tumor, less than 5 centimeters in size, then that would be either a T1 or a T2. T1 is less than 3 centimeters, T2 is between 3 and 5 centimeters. N0 means that there is no lymph node involvement, and M0 means that there is no spread outside of the lungs. So this would be considered a stage 1 in the TNM staging, and the VA staging would call this limited stage. And this particular presentation with a small primary tumor with no lymph nodes or no metastatic disease is seen in about 5% of patients with small cell lung cancer. The more common one is involvement of the lung, but involvement of the mediastinal lymph nodes or the hilar lymph nodes. The mediastinum is the middle part of the chest between the two lungs. And any involvement of lymph nodes in the mediastinum, but no metastatic disease, or stages 1 to 3, would be considered limited stage. And the reason we separate these two, I will show on the next slide, has to do with the treatment. The VA staging system divided small cell lung cancer into limited stage and extensive stage based on whether all of the disease could be confined or treated within one radiation field. If it was possible to include all of the disease in one treatment field, that was considered limited stage. Everything else was considered extensive stage. But as our understanding has improved about treatment, we subdivide further into the really small early stage small cell lung cancer, the locally advanced small cell lung cancer, and the last part, which is unfortunately the more common presentation of small cell lung cancer, is stage 4 or disease that has spread to outside of the lungs. In the VA staging system, we call this extensive stage disease, and that accounts for about 65% of all patients with small cell lung cancer. So as you can see, the majority of patients present with stage 4 disease. Why is that staging important? Because that's how we design treatment. Now, this is a cartoon that shows how treatments for small cell lung cancer has evolved since the 1960s. In the 1960s, if you had small cell lung cancer, the only thing that they could do was best supportive care, meaning treat symptoms. Cyclophosphamide came into being in the late 60s. In the 70s, we found out that cyclophosphamide by itself was good, but not very good in long term, so combined it with other drugs. In the 80s, we started getting cisplatin and etoposide. In the 90s, carboplatin came along, was less toxic than cisplatin. Then in the 2000s, late 90s, early 2000s, you had topotecan. And then more recently, there has been a significant increase in the number of drugs available with the advent of immunotherapy. And currently, two drugs, atezolizumab and durvalumab, are approved for the treatment of small cell lung cancer. A year and a half ago, lurbinectedin was approved by the FDA on the basis of a trial that showed that it was useful in patients who had progressed after platinum and etoposide. Now, when you have someone with limited stage disease, the goal of treatment is cure. Even though I showed you earlier that only 10 to 15% of patients are alive at 5 years, we still treat them with the intention to cure them. So for the really early disease, as I showed you earlier, this group of patients, the T1, T2, N0, M0, or limited stage, which make up about 5% of all lung cancer, small cell lung cancer, we can operate on them. So if we find someone who has a small lesion with no lymph node involvement, at least on our initial scans, surgery is a reasonable option for those individuals. Following surgery, we would offer them 4 cycles of chemotherapy. If on the surgical specimen we saw cancer involving the lymph nodes, we would consider radiation therapy in addition to chemotherapy. And this seems to have the best possible outcome for this group of patients with no lymph node involvement. If the patients have lymph node involvement that is obvious on our original CT scans, then the treatment of choice would be to combine chemotherapy, platinum and etoposide with thoracic radiation. And thoracic radiation seems to improve outcomes moderately as compared to chemotherapy alone. If patients respond well to your initial treatment of chemotherapy or radiation, or surgery followed by chemotherapy and or radiation, we would consider at least talk to them about prophylactic brain radiation or PCI. Now, why do we do that? Because the central nervous system or brain metastases are very common in small cell lung cancer. In about 15% of patients, the primary site or the first site where the disease comes back is in the brain. And if you look at all patients, the vast majority of them, almost 80%, will develop brain metastasis in 2 years. And we also know that once patients develop brain metastasis, their survival is not very good. The average survival of around 3 months or so. So the question arises is, can we prevent brain metastasis from forming since we know that they show up so commonly? Is there a way we can treat the brain to prevent these metastases? And studies have shown that in patients with limited stage disease who have a good response to initial therapy, prophylactic brain radiation decreases the risk of brain metastasis and to some extent increases overall survival. In patients who have extensive stage disease or disease that has spread already when at diagnosis, the PCI has been shown to decrease the incidence of brain metastasis. As far as outcomes, survival is concerned, that data is conflicted right now. There's one study that shows that the survival is improved, whereas another study showed that there was no difference whether or not you used PCI. But both studies did show that the incidence of brain metastasis was decreased with PCI. So regardless of whether or not PCI is offered to the patient, we currently recommend surveillance imaging in the form of brain MRIs for all patients. Why is prophylactic brain radiation so worrisome? Why not just give it to all patients? The reason is it can affect memory, it can affect cognitive impairment, and these are usually seen a year or two after completion of the radiation. The acute toxicities like nausea, vomiting, redness of the scalp, fatigue, alopecia are short-term and are easily overcome, but the longer-term toxicities like the brain impairment is a bigger challenge. And as time passes, that seems to increase. And that's why we are worried about offering this to everyone. Older patients over the age of 60, although many of us would not consider 60 years old, they seem to have an increased risk of cognitive impairment after radiation. And so the current guidelines suggest that if you're going to talk about PCI to patients, you need to talk to them after the initial treatment side effects have resolved. Because if the patient is still suffering from acute side effects of chemotherapy or radiation, then adding brain radiation to it will simply worsen things. Prophylactic cranial radiation is not recommended for patients with poor performance status, meaning if they are not able to function independently, then those patients tend to do badly. Patients who have impaired neurocognitive or brain function at baseline should not be offered PCI. Recent studies have also shown that a drug called memantine, which is used for Alzheimer's, using that during and after radiation decreases the risk of neurocognitive impairment. And that may be considered if you're going to offer patients PCI. Extensive stage small cell lung cancer, the main treatment is chemotherapy. Till about 2 years ago, the standard treatment was chemotherapy with platinum and etoposide. But then in 2018 and 2019, these two studies were published. One was using a drug called atezolizumab, which is a form of immunotherapy, and the other study used a drug called durvalumab, which is also another form of immunotherapy. And what both of these studies showed was that if you added this immunotherapy, either of them, to your standard platinum and etoposide therapy, the outcomes were improved. Here, the top line shows better outcomes, meaning less patients are dying from the disease compared to the bottom. And when we say placebo over here, we do not mean that the patient does not get anything. It just means that they just got chemotherapy plus a placebo as opposed to chemotherapy plus atezolizumab. So these patients also got standard of care treatment. And as you can see here, adding the immunotherapy improved the median survival by about 2 months in both studies. And they were strikingly similar, the results of both of these studies, suggesting that while immunotherapy has a benefit, this benefit may be marginal at best, about a 2-month improvement in survival. Like I said earlier, the biggest problem with small cell lung cancer is these patients relapse even though they respond very well to initial treatment. And once they relapse, they have not been very good studies looking at what the best option would be. And as a result, we have all these drugs, all of which are equally useful in treatment of these relapsed small cell lung cancer patients. The more commonly used ones are the first two, topotecan, which is FDA approved for this indication, has been since about 2000, and lurbinectedin, which was approved about a year and a half ago. The other drugs are also seem to be just as effective. It's just that the FDA has not approved them, and more likely because the company did not seek approval for this indication. How do I approach relapsed small cell lung cancer? When I see a patient who has progressed after platinum and etoposide, my first question would be, how long has it been since they last received their platinum etoposide treatment? Refractory disease, meaning that they are still on the treatment and their scans show that they are progressing. Resistant disease means that they finished the platinum etoposide, responded to it, but progressed within 3 months. And sensitive relapse is they responded to the treatment and they progressed after 3 months since after platinum and etoposide. For patients with refractory disease, there is no drug that is approved, but I tend to use either topotecan or lurbinectedin since they seem to be equally effective in relapsed small cell lung cancer. For resistant relapse, topotecan and lurbinectedin are approved, and so I tend to use one of those. For sensitive relapse, I said that sensitive relapse is anytime after 3 months. So I tend to divide those patients into whether it's been 3 to 6 months or if it is more than 6 months. If it is 3 to 6 months, I tend to use topotecan and levinectidine. But if it is more than 6 months, I tend to reuse the original platinum doublet, platinum and etoposide, and save these drugs for when I need them later. So if a patient it's been more than 6 months since the patient has received platinum etoposide, I tend to use platinum and etoposide again. And so with that, I will stop for now and turn it over to Wendy to talk about supportive care and uh, things that we can do to improve quality of life for patients with small cell. Wendy.
Thank you. Good afternoon, everybody. As Dr. Ganti said, I am going to talk about the supportive cares to improve quality of life in small cell lung cancer. As previously discussed, the staging of small cell falls into two categories, the limited and the extensive stage diseases. They are neuroendocrine tumors, exclusively in smokers, with that very small amount of women thrown in there. As Dr. Ganti mentioned, these are very highly responsive cancers to chemotherapy. We see decreases in disease but often the disease returns. The treatment of small cell cancer falls into the categories of chemotherapy, radiotherapy, immunotherapy, and those supportive cares. So different stage equals different treatments. The limited stage diseases, we use the chemotherapy, the platinum and etoposide, as we had heard about, plus concurrent radiotherapy, meaning at the same time as radiation. The extensive stage diseases get the chemotherapy, which is that same platinum and etoposide plus an immunotherapy, as we've heard about. And then relapse diseases will, depending on time since the last treatment, may get those drugs they've seen before or new agents that have recently been made available. So pre-treatment. This is where I like to sit down with my patients right before they get ready to start and have a good discussion about those medications that are going to help us with the side effects of the chemotherapy. So I always like them to be aware of any medications that may be needed to take ahead of time, so prior to the treatment before we even start. Second, I like to go through and make sure we know what's given on the day of treatment. So whether it be hydration and I should say the anti-nausea medications that will be given. A lot of that anxiety comes from, not knowing what to expect that first treatment. So if we can talk about, what to expect on that first day, especially as nausea and vomiting are concerned, those are important to discuss. And then last is that I like to make sure that there is a solid plan for take-home medications for those things like nausea and vomiting to help us after the treatment is completed for any delayed side effects. So the side effects of chemotherapy, let's talk about those for a little bit. Now, just as anything goes, just because there's a list here doesn't mean everything here is going to happen to everybody. I just like to make, patients aware of the highlights. So with these categories of chemotherapy, neutropenia would be the highest on the list that I make sure, I really tell patients if you don't remember anything from our visit, we just need to remember that risk for infection and when to report fever are very important. So neutropenia is a decrease in the white blood cell counts and a higher risk for infection. Next would be anemia. Those are a drop in the hemoglobin and hematocrit that can cause symptoms like shortness of breath, perhaps, some chest pains, or just overall fatigue, feeling ran down, not having any energy. Thrombocytopenia would be a low platelet count and risk for bleeding. So here we discuss nosebleeds, gum bleeds, or perhaps little purple prickly spots that may occur on the skin. Loss of appetite and taste changes resulting in weight loss. The taste changes are sure to happen with chemotherapy, so important here to talk about how eating really needs to be a job. Although you might not have an appetite or things taste awful, it needs just to be something that, You tell yourself every couple hours, I'm going to try something small, just so that we're not having a big weight loss. This is also where I like to let patients be aware that we do have dietitians on our team, or even local resources that can help, like, the dietitian at your local grocery store. Anything to help us with those taste changes, or, come up with good ideas on how to keep the calories coming in. Hair loss and body image disturbances. So these categories of chemotherapy are likely to cause hair loss. So being aware of your American Cancer Society local chapter that perhaps has wigs or, scars that you can, that are available. Otherwise, does your practice or your facility that you're going to, do they have an image recovery center that helps with those things, like, wigs and overall recovery groups? Mouth sores kind of go along with the whole drop in the white blood cell counts, can also be thrush. Those can also impact the ability to eat and lose weight. So those can also happen. And then fatigue. Fatigue happens, I say, in 100% of patients. We're giving stuff that's foreign to the body. So we need to keep in mind that this is going to happen. However, the best way to combat fatigue is to keep moving, keep yourself active, even if it's during the commercials at your, with your favorite TV program that you're going to sit and watch. It's keeping active, but this can be, a symptom that very much, or side effect that impacts quality of life. Next, nausea and vomiting, like we've talked about, body aches and pains, peripheral neuropathy or numbness and tingling that can happen in the hands and feet and can also turn into some pain. Constipation, diarrhea, rash, and swelling are also things that can happen with chemotherapy. So let's talk about some psychological side effects that go along with the cancer diagnosis. Anxiety, just the whole, what am I going to do now? Perhaps even before you have your first initial visit, what are they going to tell me? All those unanswered questions, and then, further, what to expect with the first treatment, or, your treatment plan as it goes along. And then we can run into some guilt and regret, right? So we talked about this being a mostly exclusively smokers' cancer. So is there some guilt and regret about, why couldn't I give it up? Why didn't I stop smoking? Those things can, also occur. And then anger over the whole situation. Why me? Why did this have to happen? Why now? And then overall sadness related to the situation. And then other considerations can be age, because we've talked, folks are living longer these days. So we have a lot of anybody that comes to have a consult with us, we talk about the age as a consideration, but not enough that would exclude anybody from a treatment. Comorbidities, though, go along with age. So the older we get, the more issues we might have. So we want to make sure we know and are aware of other health issues that a person might have that may influence or impact their treatment. And then financial concerns. Let's face it, cancer is expensive, right? So, worrying about missed time at work or needing to get family medical leave filed. And further, if it goes on to disability, how that looks. Make sure that you're aware of any social workers or outside resources that may be able to help with this. Okay, so let's talk about chemotherapy side effect management. Biggest thing that I tell my patients is you have to know who to call. So whether it be your nurse, because different places or different health systems, different doctors, could be that they use different titles for these people. So it could be a nurse they call, your nurse case manager, your nurse navigator. Most importantly, just know who your person is and who's going to help you navigate this journey. So your best friend during your treatment. Also important that we talk about knowing when to call. So back to that whole infection risk, fever. Fever is the most, is the highest on the list here of knowing when to report to your doctor. So know what your doctor likes for the reading of when you need to call. For example, if it's like ours, 100.4, know when you need to call and report that fever 24 hours a day, 7 days a week, know who to call for that and when. Nausea and vomiting, that's not relieved. So I don't like my patients to think they have to max out on all their nausea medications before they call. So, you know, hey, I've tried this and it's not getting any better. We should know about that. If you're unable to eat or drink for more than 24 hours, that can lead into a dehydration issue. We should hear. Diarrhea, or more than, we say max of 5 watery stools above your daily normal. Leading into that being a problem, you know, again, for dehydration to come. Constipation for more than 2 days. So if you're somebody that's experienced constipation in the past, this can be just as awful as anything else. So we should be aware of that. Uncontrolled pain. Next would be a new cough or coughing something up, new shortness of breath, or a change in your current shortness of breath. So thinking about a cough and shortness of breath, I always try to say, okay, we need to take a stamp in time right now, or this is what I feel like right now. This is what my cough feels like. This is what my shortness of breath feels like. So have those things change. Do those feel different to me? And then changes in mental state, like, you know, you're really drowsy, or perhaps your family or friends, somebody's reporting to us that you're a bit confused. Would be another thing to call about. Examples of supportive care with chemotherapy. So these would be, you know, the antidotes or what we can do to help support you during the chemotherapy process. So anti-nausea medications or steroids that can be given intravenously for the nausea and vomiting. We can also do fluids by IV for dehydration or that poor oral intake, not getting much, you know, to eat or drink. Over-the-counter prescription medications for diarrhea. These 3 things kind of all go together, where we can also do fluid, you know, IV replacement for that diarrhea. Any type of fluid loss, whether it be, you know, vomiting or diarrhea, those can also affect electrolytes. So it could be that we check some lab and replace those electrolytes to help you feel better. Anemia or enema or over-the-counter prescription medications for constipation, pain medications, or what we would call an ill visit, to come in and see your provider or another provider to evaluate for those signs of infection or newer worsening symptoms or side effects from the chemotherapy, to get a second set of eyes on you, to just be evaluated to see is there more we can do to support you. Prescription medications for neuropathy, if that would turn into be a painful situation. So moving on to radiotherapy. As discussed, we give this at the same time with chemotherapy in those limited disease patients, or alone for pain control. The goal of that radiotherapy that's given with the same time as chemo would be for long-term control of disease. Otherwise, the palliative radiotherapy goal is for control of symptoms such as that pain to improve quality of life. I like to say, much like a sunburn, you know, it could be that redness and that awful side effect of that burn doesn't come on right away. It's the same thing as radiation. So that side effect usually comes in, or, you know, you start to really notice that about 2 to 4 weeks after the start of therapy. Because that chest area also includes your throat and esophagus, and those are directly insulted by the radiation, we can also see open ulcers or sores in the mouth and throat that can happen that further may extend down into the esophagus. Those could also go into leading on to some difficulty swallowing that then further would cause some weight loss and dehydration. Pain in the affected area, so anything that's being radiated, as you can see in the picture, you know, that red area can be painful. And then esophageal reflux. So if you have a history of that particularly, can also be a problem with radiotherapy. And then skin irritation, fatigue. Once again, we're doing something that your body's, it's not normal. So fatigue will, and for sure happen with that most of the time. Pneumonitis, or an inflammation of the lungs, can also happen, going back to the whole need to report a change in shortness of breath or your cough. So side effect management with radiotherapy is more of a proactive approach rather than waiting for side effects to occur. So for example, practicing good oral hygiene, taking really good care of your mouth and teeth, avoiding any alcohol containing products, for as far as toothpaste or mouthwashes go, using just a baking soda salt rinse if you need to. So absolutely caring for your mouth during treatment, after treatment with the radiotherapy is important. Making dietary changes, or asking your team again about that dietitian to help us with extra guidance as far as things change and we progress further along in the course of treatment. We know what we can do to keep those calories coming in, to keep your energy up. Pain control. Pain control is a must. We have to have a solid plan in place to help control the pain. This will likely include a prescription mouthwash to help with those sores that we've discussed. The esophageal reflux management. This can be medicine or a non-medicinal approach, but to make your team aware of those. Now, in cases of severe pain, weight loss, inability to swallow, maybe that we need to help support you throughout your therapy with IV fluid management or pain management. Rarely we see that we have to put a feeding tube in to bypass the stomach and to just directly get that nutrition and medications in. Also important to mention that we are taking real good care of the skin and that you're aware of what your radiation doctors want you to do with your skin in that affected area, how they want you to use creams or whatever it be and when. Next, let's talk about immunotherapy in small cell lung cancer. It, like Dr. Ganti mentioned, is a more recent addition to the treatment of extensive small cell lung cancer. Immunotherapy works by stimulating your immune system to recognize and kill the cancer. So separating that bond and having your immune system then see something as foreign and directly get it that way. Contrary to chemotherapy that will go directly to a cancer cell to cause cell death. Immunotherapy is more by ramping up the immune system. Let's wake it up. Let's, see all these things as foreign and take care of them that way. This slide demonstrates everything and most everything that can happen as a result of the immune system being hyperactive with these agents. So some of the side effects to report related to the immunotherapies. So skin rash, itching, and sores. Now that we have used these immunotherapies for longer, we are seeing that this, by far is one of the most common side effects we see. And to stay ahead of this, we are recommending that our patients start with a very basic skin cream, one that doesn't have alcohol in it. So scented things are the things that come out of a pump. Most always will have alcohol in them. So something that comes out of a tub that's fairly thick, probably oily, but you wash your hands real well, you get your skin real nice and moisturized every day. That we have seen as a good way or a proactive approach to this. And then, if that comes on to become more of a rash, that would be something that we would have you definitely need to notify your care team of. And then any open sores. Diarrhea or blood in your stool or severe stomach area pain, those can just go back to, your immune system being stimulated in your bowel or in your stomach. Extreme fatigue. Now, fatigue here would be very daily living, limiting fatigue. So I can't get out of bed today. I just can't move. I just can't do anything more. That kind of fatigue. New or worsening cough and shortness of breath. As we talked about before, this is not the same symptom or not the same thing that made you aware of the lung cancer. This is something that feels completely different to you. Severe or persistent joint pain or severe muscle weakness. This is something else we're seeing quite a bit more of with the use of these agents. So making your team aware of those to see, is there somebody else we need to help us navigate these so we can get through the treatment. A decreased amount of urine or blood in your urine should be reported. Any changes in mentation, going back to confusion, mood changes, behavior changes. Any changes with the vision, so blurry vision, double vision, should be reported. Dizziness, fainting, headache, rapid heartbeats, weight loss or weight gain, and then the yellowing of skin or whites of the eyes. So because we just said that the immune system is hyperactive or revved up with these, it's not as simple as you thinking, I'll just go to the store and get some anti-itch cream, or perhaps I'll just go take an antidiarrheal. It could be that we need to move on to something called a corticosteroid. These side effects are treatable, but your team needs to know about it. So I always say I can't help unless I know about it. So keeping your team updated with what's going on. Takeaway points from today, or the highlights I like to make sure everybody knows, is, again, know who to call, know who your person is, know when to call. So the high points of, those side effects, not trying to deal with this all on your own, calling your person. And most importantly, remember, we're all in this together. Next, I will hand back to Dr. Ganti.
Thank you, Wendy. I'll talk a little bit about some of the new things that are going on in small cell lung cancer today. And as I mentioned previously, our outcomes from small cell lung cancer are fairly dismal. Only about 15% of patients with small cell lung cancer live to be 5 years beyond their diagnosis. And clearly something needs to be done to improve those numbers. One of the first things to do in those situations that we've learned from other cancers is to try and understand the biology of the disease. What do I mean by that? We all know that even though we call these cancers as lung cancer or breast cancer, they have multiple different mutations that drive those tumors. And treating a cancer that is driven by mutation A with a drug that affects mutation B clearly is not going to help. So one of the challenges that we faced all along is we've not been able to identify subtypes of small cell lung cancer, or what is it that drives small cell lung cancer. And in the last couple of years, that seems to be changing. As you can see on this slide here, recent research has suggested that small cell lung cancer can be divided into 4 different subtypes, and each of these is driven by certain distinct genes, and therefore targeting these genes may improve outcomes. Like, for example, small cell lung cancer A, it makes up about 70% of all small cells, and that seems to have 5 or 6 different drivers here, including DLL3, BCL2, CREB-BP, LSD1, and MYC. SCLC-Y seems to make up about 8% of all small cells. It's driven by a protein called CDK4/6. It's a group of proteins. SCLC-P seems to be driven by this protein IGF-1R, which interestingly is also seen in non-small cell lung cancer. And SCLC-N makes up about 11% and is driven by this protein MYC, which is seen in a type of lymphoma called Burkitt's lymphoma. And certain viruses seem to be causing this SCLC-N. And the reason this is important, this classification, is because they seem to respond to different therapies. For example, just as an illustration, in 1985, when we didn't know what the subtypes of small cell lung cancers were, we basically treated all of them with platinum etoposide with or without radiation. And now that we know some of these different subtypes, we are beginning to get information to suggest that different subtypes respond to different treatments. Like, for example, SCLC-A seems to be more sensitive to inhibitors of the protein BCL2, inhibitors of DLL3, HDAC or LSD1. SCLC-P, which is driven by IGF-1, seems to respond to IGF-1 receptor inhibitors, PARP inhibitors. SCLC-N seems to be respond better to the aurora kinase inhibitors and the MYC inhibitors. And like I said earlier, there's a group of small cell lung cancer that seems to be driven by the Seneca Valley virus. And so treatments targeting the Seneca Valley virus seem to be effective against the SCLC-N. And lastly, the SCLC-Y seem to respond better to the immune checkpoint inhibitors or immunotherapy. Of course, all these studies are currently being done in the lab in preclinical models, animal models, and it's not ready for prime time yet. But we are hopeful that some of these treatments may become approved in the next few years, and we will be able to get personalized therapy based on the mutations that are driving the cancer, rather than a one-size-fits-all approach, which we tend to do today. So these are slides, the next couple of slides will show you some of the new trials that are being done. This is the immunotherapy, and as you can see, the response rates are around 10 to 15% with progression-free survival, meaning the patients tolerate treatment for about this amount of time, about 2 months before they progress, and overall survival seems to be about 6 to 8 months. Although if you look here, patients whose tumors have this PD-L1 protein seem to have a higher survival when they are treated with pembrolizumab, which is an immunotherapy agent. Similarly, these are some of the targeted therapies that are used for other cancers. Response rates are around 15 to 20% here. Again, progression-free survival is about 2 months. Overall survival is about 6 months. This particular drug, rovalpitazumab tesirine, is an interesting drug because it was the first drug that is shown to target DLL3. And as I showed you earlier, DLL3 is a protein that is commonly expressed in SCLC-A. And so this drug targets this particular protein and seems to be effective in those patients who have that protein. Unfortunately, this drug is very toxic, and so it's no longer being developed commercially because of the side effects. But at least this led the way to the understanding of this protein DLL3, and there are currently other drugs in development that may target this better and in a safer manner. For the last part, I would like to talk to you about clinical trials and the importance of clinical trials. NCCN believes that the best management of any patient with cancer is in the context of a clinical trial and strongly encourages participation in clinical trials. Reason for that is that every cancer treatment available today is the direct result of clinical research. Clinical trials provide scientific evidence to determine whether experimental treatments, devices, and procedures are safe and effective. Even if a trial is negative, that provides useful information. And one of the things that I have noticed and always tell my patients is even if you're on the standard treatment arm of a clinical trial, studies have shown that you do better than if you receive the same standard treatment outside of a clinical trial. So this is the whole life cycle of a clinical trial. So you have a molecule that shows some benefit in the lab, basic science discovery. Then that is next tested in the laboratory in animals, cell lines, and if it shows success in those experiments, then it goes to phase 1. Phase 1 is where we look at the side effects and the side effect profile of the various drugs to find out if they are safe. Once we find out that they are safe, then they go to phase 2, which takes a larger number of patients, and the goal of a phase 2 trial is to see if those drugs are effective. Now, once we find that those drugs are effective in a phase 2 trial, we then take them to a larger phase 3 trial where we compare them with the standard of care, whatever that may be. And if it could be adding the new drug to the standard of care, or it could be substituting the standard of care medicines with the new drugs. And if that approach is successful and the new drug is shown to be either better or safer, then that gets FDA approval. Once the drug is approved by the FDA, then it goes to phase 4, which is after approval, we still study those drugs to make sure that there are no uncommon side effects that were not detected in these initial clinical trials. And the eventual goal of all these trials is to improve the standard of care for that particular condition. There are a number of clinical trials in small cell lung cancer that are currently being tested. On this slide, I have a few common examples of NCI-driven trials that are being conducted nationwide for small cell lung cancer. S1929 looks at those patients with small cell lung cancer that have this protein schlafen-11 or SLFN11 and uses a drug called olaparib to see if adding olaparib after completion of chemoimmunotherapy will help benefit patients with SLFN11 positive small cell lung cancer. The Raptor trial LU007 looks at the addition of radiation therapy to immunotherapy and chemotherapy for extensive stage small cell lung cancer. LU005 looks at the combination of atezolizumab to chemotherapy and radiation for limited stage small cell lung cancer. CC003 looks at whole brain radiation with or without hippocampal avoidance for patients who are receiving brain radiation for small cell lung cancer. And the basis of this study is previous studies have found that if you avoided radiating a part of the brain called the hippocampus, which is responsible for memory, you could potentially avoid the cognitive dysfunction associated with brain radiation. But those same studies also showed that avoiding the hippocampus does not necessarily increase the risk of cancer coming into those areas. So this is a study that's quite exciting where we do whole brain radiation, radiating the entire brain or avoiding the hippocampus, and the goal is to see what its effects on neurocognitive function are. And the last study, S1827 or the Maverick study, looks at the use of brain scans to follow those patients with small cell lung cancer versus radiating them early, prophylactically radiating them to see which approach would be better. So I hope I have given you a example of the different types of research that is being done currently in small cell lung cancer. This list is by no means comprehensive. There are hundreds of different trials that are ongoing. I just thought I'd present some of the NCI sponsored trials that are ongoing today across the country. With that, I will stop and hand it over to Charles to talk about clinical trials and from a patient perspective.
As a patient, lung cancer survivor myself, as well as several other cancers, I've learned over the years the importance of clinical trials and have been involved to a great extent as part of my patient advocacy in reviewing clinical trials that are going through the process of being approved before they start at UT Southwestern. I'm sure that many committees are like that throughout the country at other institutions. It's just one of the stages of clinical trials is having them reviewed by the various medical specialties at a medical center and a patient advocate as well, representing the interests of the patients. What I do primarily in reviewing clinical trials is reviewing the informed consent, and I'll get back to that a little bit later. One thing that I try to dispel when I talk about clinical trials is this idea that you're simply a guinea pig when you're in a clinical trial. That's just simply not true. Many patients involved in clinical trials are actually getting their best chance of survival because they're on the cutting edge of new drugs or procedures, various treatment modes coming down the pike, where otherwise they would not be available because they're not FDA approved. Many patients in clinical trials, and the qualification of those patients is that they've gone through cancer treatment standard of care and they've been unsuccessful, and this is basically their last hope. And hope is the key to me to clinical trials. Every cancer patient, the best thing they have going for them is to have hope. And clinical trials are always out there. Cancer is changing. Treatments are changing. Everything about cancer changes because of clinical trials. What is a standard of care today, treatment, may not be standard of care tomorrow because of the advances in patient treatment as a result of clinical trials. What are the benefits to the patient? You're playing an active role in determining the direction of your healthcare, for one thing. As you know, in the cancer care and cancer treatment, it really is a team effort, and the patient is involved and should be involved all along the way. And your decision to go into a clinical trial is an additional example of how you control your medical care. The most important one, I believe, as I've already mentioned, is that you have access to new treatments before they're widely available. Third one is you receive expert medical care at leading healthcare facilities all along the way. And the fourth, and very important, is you're helping others by contributing to medical research. You're not a guinea pig. You control your care. You decide if you're in the clinical trial, and you can opt out of a clinical trial if you wish during the course of a clinical trial. You're not like a guinea pig that's there to be experimented on. You're there to be treated and to help in the treatment of cancer. There are various types of clinical trials. 5 are listed here. Diagnostic, which develop better tests and procedures for diagnosing cancer. Treatment trials, where they test new treatments or new ways of using existing treatments. Prevention trials, where you're involving healthy people who have not had cancer but are high risk for developing cancer, or have had cancer and are high risk for developing a new cancer. Screening trials, new ways to find cancer early when maybe more easily treated. In my case, I've had 5 stage 1 cancers. Early screening has saved me, and I know the value of these screening trials. The 5th is quality of life, supportive care, and palliative care trials. This is to improve the quality of life of the patient, to diminish the side effects of treatments, to enable them to survive and flourish during the course of treatment. Questions to ask about clinical trials. Now, this goes back to the informed consent. In every clinical trial, there will be an informed consent prepared for the patient to review. It should answer most, if not all, of these questions. If it doesn't answer these questions, then you need to ask those questions. What my role is as a patient advocate in reviewing clinical trials is to make sure that a patient can understand what is being presented in the clinical trial. It's in a sufficient language that we can understand it and know what we're getting into. The questions that I have listed here is, what's the goal of the clinical trial? What's the end result? Is it to find a cure? Is it to extend life? What is the purpose of the trial? Has the treatment been studied before? Is this something that has a basis in fact that it's been studied before? What are the results of those studies? And what are the chances of this clinical trial being successful? At what phase is the clinical trial? Stage 1, 2, 3, 4. You need to know that. The higher the stage, the more advanced the trial is, and the more you will be involved, the success of possibility of being involved in the treatment itself. Will my care change based upon my response to the treatment provided during the trial? What are the risks to me in the trial? The informed consent will normally list the side effects and the various risks, known side effects, and they will categorize those by common, rare, that sort of thing. What benefit, if any, will I receive from the trial? You may receive no benefit. It may be something that benefits future patients. You may actually have a successful treatment. Some of these trials last multiple years, and you'll be asked to come back in and have tests and fill out surveys and all sorts of things. You'll have to pay for participation in the trial. Will I be compensated for participating in the trial? Sometimes there is compensation. Will my insurance cover participation in the trial? Sometimes insurance will not cover trials at all. Most of the time, they'll cover at least part of it, and the remainder is usually covered by the drug company or the other sponsor of the trial, the medical center that's conducting it. That'll all be spelled out in the informed consent, but you need to know that. Can I leave the trial at any time? Can I be terminated from the trial? And what information will I be given regarding the results of the trial? It's always nice to know when you've been working on something for a couple of years, am I going to find out what the results of the trial were? Was it a success? Did it help? All those questions are very important, and they should be in your informed consent. But if not, you should inquire of that with your physician. The next question is, how do I find a clinical trial? That's of utmost importance. And you have to realize that clinical trials are all over the country. Sometimes they're in one cancer center, sometimes they're in multiple around the country. Is that clinical trial going to be convenient to me? What are the requirements? Again, I'll go back to my questions for me to come to this center to participate for checkups, testing, and that sort of thing if it's not near my location. Who's paying for my travel? All those are questions that need to be answered. But how do I find a trial? Your healthcare provider is in nurse navigators. Those who are involved in your direct care at the present time are your first source. Other sources, if you're not near a medical center, is a medical center, such as UT Southwestern, MD Anderson, Moffitt. Those centers will not only have trials conducted there, but they'll also know what other trials are being conducted around the country. The next is advocacy organizations. Advocacy organizations in lung cancer are extremely good. Believe me, I've been involved in several of them. Just for clarification, I was on the board of the GoTo Foundation for Lung Cancer, and I'm still on the Emeritus Board. But these are the 4 leading lung cancer organizations in the country. They normally have access to clinical trials and are anxious to help you with your journey trying to find the appropriate clinical trial. They also have a variety of other services as well. As an example, and I'm just using GoTo because of my affiliation with them, if you look down the bottom right-hand corner, Lung Match, they have a program called Lung Match that helps you locate a clinical trial. They also have a variety of other services similar to what, and your other lung cancer organizations have similar services. Now, another good source is the NIH website, which is at clinicaltrials.gov. That has probably the best, most comprehensive list of clinical trials, and you can put in search parameters for that to also locate an appropriate clinical trial. Now we'll move on to the Q&A part.
Thank you. So yes, now is the Q&A portion of the webinar. Maybe to start off with, Charles talked about one of the concerns is being a guinea pig in clinical trials. So presenters, what are some of the other concerns you've heard about, what people have said about clinical trials, and what do you say in response?
I'd like to say what I hear from patients when that's brought up is, what happens if I change my mind? Am I committed to this forever? Can I get out if I want to?
So I think the questions that Charles had on the ask your provider regarding clinical trials, I mean, those are kind of the common questions that we often hear. And the other question that I often get is, can I have a choice, or can I decide which arm of the study I'm going to be in? If the study has more than one arm, can I decide which arm I'm going to be in? And usually the answer is no. It is randomized, and neither the patient nor we have any choice in that. It is randomly decided by a computer, a flip of a coin, if you will, and we get told that your patient is going to be in this arm of the study.
We have a few questions that have come in, so I will hand it over to Wendy.
Okay, the first question here says, what level of fever do you ask patients to report? Do they call the office or do they go to the ER? So our facility number is 100.4, and what we ask for patients to do is, our desk lines are all able to be routed over to our triage center, which is, we don't outsource, it's our own cancer contact center, which then routes to our oncology fellows and then to our staff. So we always ask that patients call our number first rather than going to the ER, because, the ER is what it is. Now that's kind of tricky though, because we do see patients that aren't local. So it could be that the only option for patients that aren't local to us would be us directing them to go to a local ER. Next question here, I think would be a good one for Dr. Ganti. Do you recommend prophylactic medications to prevent or manage neutropenia?
I typically do not recommend that because when we're giving chemotherapy in combination with radiation, prophylactic growth factors, which would be commonly used, are contraindicated because they can suppress all blood counts. And one common problem that we have seen is they can suppress your platelet counts more than what would otherwise be seen, and it will not necessarily change the outcome in terms of how soon you will get your next chemotherapy treatment. Growth factors have been shown to decrease the duration of the time in which your counts are low or decrease the duration of neutropenia. They do not decrease the side effects of neutropenia, meaning they do not decrease the risk of infections. They do not decrease the severity of infections. They do not decrease the hospitalization from infections. All they do is decrease the duration of low blood counts by about 1 or 2 days. And well, like I said, when we're giving it with radiation, we increase your white count and decrease the duration of neutropenia, but at the same time decrease the platelet counts. And so if your platelet counts are low, you still cannot get chemotherapy. So there's no real need. When I do recommend these growth factors is if someone has already had a neutropenic fever episode on a previous chemotherapy cycle, and I'm using the same treatments. In those situations, I would definitely recommend using growth factors to prevent the risk of neutropenic fever again.
Okay, the next question here, how long after stopping IO or immunotherapy should people monitor or report side effects? I'll start by saying, I always like to say a call is easy. We're not bothered by a call, that's easier for the patients. So a call is easy for us to, talk somebody through this. But Dr. Ganti, would you like to expand a little bit on maybe how long people might have these?
Sure. The thing about immunotherapy is I liken immunotherapy to an alarm clock. Like in the morning, you turn your alarm clock for 6 o'clock. You wake up, yell at the alarm clock, shut it off. The alarm clock shuts off, but you don't go back to sleep. It's the same thing with the immunotherapy and your immune system. Even after the immunotherapy is no longer being given, your immune system can continue to be upregulated or more active. And just like it can prevent cancer and from growing for a long time, the side effects can occur for a long time as well. I have seen situations where people have developed immunotherapy related side effects more than a year after they've stopped immunotherapy. So that's something that is to be considered. And if you've received immunotherapy ever, you could still potentially get those side effects.
Okay, how about who would you call regarding fatigue issues? Again, it's going back to that, who's your nurse case manager, your nurse navigator. And then at the visits, it's important when you see your provider to discuss how much fatigue you're having. Sometimes we need to do a little bit of digging. Is this a blood count issue? Is this a side effect? Are these things that have potential easy things or easy fixes? Or do we need to consider something different for the fatigue? Are there any immunotherapies available to people that have stable microsatellites and a low tumor mutational burden? And can these be successful? Dr. Ganti.
Immunotherapies have been approved for all cancers that have high microsatellite instability and a high tumor burden. The thing about small cell lung cancer is the studies that were done did not specifically exclude patients with stable microsatellites or low tumor mutation burden. And so anyone who has extensive stage small cell lung cancer is a candidate for chemoimmunotherapy. And according to the NCCN guidelines, if you have not received immunotherapy as part of your initial treatment, you potentially would be a candidate for immunotherapy if the disease has relapsed. So to answer your question, Yes, immunotherapies are available to all patients with small cell lung cancer, regardless of their tumor mutational burden or microsatellite status.
Okay, here's another one, Dr. Ganti. I'm not aware. Is lurbinectedin available in the EU?
I believe it is. The company that makes lurbinectedin is based out of Spain, and their original studies were in Europe. So I believe that they are approved in Europe, but I'm not sure.
Next question. Biomarker testing is a standard of care in non-small cell lung cancer, but I have heard very little about biomarker testing in small cell lung cancer. Is this something that is showing promise? If not, why not?
We have been on the lookout for biomarkers in small cell lung cancer for a long, long time. One of the biggest challenges in small cell is the amount of tissue that you get on a biopsy specimen and the amount of viable tissue. Like I showed you in those pictures, those big blue cells, when we do a biopsy, most of them are already dead. And it's a challenge to make a diagnosis. And that is what has limited our use of biomarkers in small cell lung cancer for a long time. Now that our techniques and our strategies for testing biomarkers has improved substantially, we are beginning to look at various biomarkers. For example, in the slides that I showed you where we had the different subtypes of small cell, those are examples of biomarker-driven small cell lung cancer. And in the clinical trials, I showed you an example of a biomarker-driven study in lung cancer looking at a protein called SLFN11. And so we are just beginning to start looking at various biomarkers in small cell lung cancer. And hopefully in the next few years, we will have biomarker testing for small cell lung cancer just as commonly as non-small cell lung cancer.
How long after the last session of chemotherapy does it typically take for a CT scan to be performed to assess how the treatment has performed? Dr. Ganti.
I tend to get CT scans after about 2 cycles of chemotherapy. The general recommendation is every 2 to 3 cycles of chemotherapy, you should get scans and to see if the treatment is working and if the cancer is responding. Having said that, different patients respond differently to treatments. And if at the first scan, your doctor tells you that you have stable disease, that is not necessarily a bad thing. Stable disease means that the cancer has not grown, and that means that the chemotherapy or whatever treatment you're getting is doing something to prevent the growth of the cancer. Yes, all of us would like the treatment for the treatment to shrink the cancer and make the scans look better. But even if it is stable disease, it is not a bad thing.
Here's a question. How long is immunotherapy recommended for to determine its effectiveness? Dr. Ganti, would you like to answer?
Sure. Immunotherapy works differently from chemotherapy in that it does not directly affect cancer cells. Chemotherapy directly kills the cancer cells, whereas immunotherapy works to stimulate your immune system and indirectly kill the cancer cells acting through your immune system. So studies have shown that typically the responses will start occurring by about 6 weeks or so, but it is my practice to wait for at least 3 months to get a scan, simply because even if there is a response, it may not show up in the scans where we look at the decrease in the tumor shrinkage and decrease in the size of the tumor for about 3 months or so. So as long as the patient is doing well, feeling well, and has no side effects or no new symptoms, I would like to continue immunotherapy for at least 3 months. You can see responses sooner than that, but I would definitely wait for at least 3 months to decide before deciding that it is not working.
Okay, next question is, what exactly is meant by non-small cell lung cancer being a neuroendocrine tumor? What is the mechanism or makeup of the tumor that is given to this classification? I think perhaps the question is meant to say small cell lung cancer being a neuroendocrine tumor.
Neuroendocrine tumors are a group of tumors that are characterized by specific staining patterns. Like I showed you, there are two specific stains that we use, two specific proteins that we look for, synaptophysin and chromogranin. And any tumor that has the presence of those two proteins is considered a neuroendocrine tumor. You can see neuroendocrine tumors pretty much anywhere in the body, right from the nose all the way down to the rectum and skin. Small cell lung cancer is one of those. It is probably the most aggressive neuroendocrine tumor. And the reason we call it neuroendocrine tumor is because it has those two proteins. There is a subset of non-small cell lung cancer as well that is classified under the term of neuroendocrine tumors. That is called large cell neuroendocrine tumor to differentiate it from small cell lung cancer. And the big difference between those two tumors is that small cell lung cancer is very sensitive to chemotherapy and radiation, but tends to relapse, whereas large cell neuroendocrine cancer is not as sensitive and can be treated like a squamous cell cancer of the lung or as an adenocarcinoma of the lung.
This
That
one looks
answers your
like
question.
this next one I think is for you too. What are the characteristics of the 3% that survive 1 to 5 years?
That is an excellent question. I wish we knew that. If we did, we would be focusing more of our efforts on trying to figure out why they do well and why they do not. And one of the challenges for long has been the lack of technology to try and determine the differences in the tumor biology of these cancers. Hopefully that will help as the ongoing research with small cell. As someone mentioned in the chat, the Small Cell Research Consortium that is collecting specimens and trying to understand the kind of questions that you're posing.
The next question here is, are paraneoplastic syndromes checked for with blood work or by symptoms only? Likely both, right, Dr. Ganti?
Yes, usually symptoms drive the testing that is done, but the treatment of paraneoplastic syndromes the underlying treatment is to treat the cancer itself. So while I do use blood tests to get to the diagnosis of paraneoplastic syndrome, I tend to base my treatment solely based on symptoms and basic lab tests rather than looking for fancy paraneoplastic panels which take weeks to come back and do not necessarily affect the way I treat patients. So symptoms are what I drive treatment based on, but blood tests are mostly to confirm that.
Do you recommend 4 or 6 cycles for first-line chemotherapy, immunotherapy?
I would use 4 cycles of chemoimmunotherapy together, and then if a patient is doing well on that, I would switch to just maintenance immunotherapy, which is the way the trials were done.
When would clinical trials be recommended or introduced to a new patient who is recently diagnosed?
I would recommend clinical trials right from the beginning. I think if there is a clinical trial available for a particular situation, I think it should be recommended. And Charles, I would like your thoughts on that as well.
I agree wholeheartedly. The lung cancer patient, again, takes charge of his treatment that way. You got to be aggressive with every cancer. Take advantage of whatever opportunities are out there to secure whatever cutting edge treatments you can. And I think the earlier you get involved in the clinical trial process, the better.
Looks like the last question here we have time for. Can an extensive stage small cell lung cancer patient receive preventative brain radiation, I believe?
The answer is yes, they can receive, but the magnitude of benefit for an extensive stage small cell lung cancer patient receiving prophylactic or preventative brain radiation is less and has to be balanced with the side effects associated with brain radiation. So I would talk to my patients about the pros and cons of doing prophylactic brain radiation, even with extensive stage, and talk to them about what the benefits are, what the risks are, and help them make a decision of whether or not they want to do it. If we decide that we do it, I typically tend to do it after a month of completion of chemotherapy. And then we don't know whether immunotherapy should be held or stopped for that period of time or not. I tend to go by how symptomatic the patient is and how did they tolerate the chemotherapy and radiation. If they are doing well, I might continue the immunotherapy while they are undergoing brain radiation. Whereas if their performance status or functional status is marginal, I might hold the immunotherapy, have them complete their brain radiation, and then resume it.
Thank you. We are out of time today, but I would like to thank the presenters for their time. It was very comprehensive presentations, and I would like to thank everybody who attended. And the NCCN Foundation would like to thank the corporate supporter AstraZeneca. Have a good day, everybody.